makes hormones that targets the ovary to make the ovary do something, make eggs, recruit little eggs. It will recruit sometimes 500 to 1,000 eggs total from both ovaries, mostly microscopic. Now, at about 7 to 9 days into that cycle, there's one that it's a few millimeters bigger than the rest, and it kind of inhibits the growth of all the others.
Okay.
So they stop growing, and then you only have one. Now, like let's say 2 weeks into a 28-day cycle, that would be the middle of the cycle. That that follicle, as it's growing, is making estrogen. And as the estrogen levels start to go up, it's like a thermostat. Like if that's what your body says, the estrogen level is doing this. And once it reaches that level right here, then the brain triggers and sends an LH hormone surge that releases the egg.
Okay.
So that little follicle's here, and it releases, the egg comes out, it goes into your fallopian tube, which then goes into the uterus.
Oh, okay.
And intercourse around that time of ovulation, the egg and the sperm can meet up.
Okay.
And usually then it fertilizes somewhere in the tubes, and then it implants in the uterus. So your ovaries are still doing the same job every month, letting a little egg go, but it's just kind of floating around, and then it just goes away. So it's a sad little story now, right?
Yeah.
It's got nowhere to go. However, that's good for us because we know that kind of roughly when your cycle is going to be. And are you the type of person who can feel like when you might be ovulating or not?
Sometimes I still have that. Usually when I used to ovulate, I will have like a slimy discharge. Sometimes I have those, but otherwise I still don't feel the tenderness and all of that. Not anymore. And then I get some cramps here and there, like signaling that I'm in my period or something.
Now, they removed the entire uterus, right? Not just part of it?
And a part of my cervix.
Part of the cervix, okay. So no more bleeding, not even a little spotting each month?
Sometimes I do. Like, I think twice since the hysterectomy, I've had some bleeding.
Yeah, there are some little glands in that cervix that could respond and also make that cervical discharge, right? That's what, it's kind of like an egg white, is what we say.
Right, exactly.
Yeah. That's exactly what it's like. And that's in response to the estrogen that's being made from the egg, which is in the ovary. Okay. So it's interesting. Remember, the brain goes to the ovary. It makes those hormones. Those hormones from the ovary go back to the brain just to kind of say, turn down the stimulation. Everything's going fine. But the hormone estrogen from the ovary also goes to the uterus to tell it to make that lining stop bleeding. That's why your bleeding stops mid-cycle. And it gets ready for the embryo to implant. So it's funny, they're all communicating, but it's not like they actually know that anyone else is there, right?
Right, okay.
So what you do is...
I still have my hormones and everything active? Okay.
Oh, yeah, no, totally active. There's just no place to hold a pregnancy now. Yeah, so that's where we come in. And the reason I spend the time on that is because what we do is we give medications to take the normal stimulation that your brain would do to the ovary, but we increase that stimulation to recruit multiple eggs, not just one.
Oh, okay.
Pretty interesting, right? I mean, interesting that we can make all this happen, and you don't need a uterus to make it happen, yeah? So medications will do that. As these follicles grow and get bigger, it's easier for us to get those eggs out. Now, I'm kind of ahead of myself, but... then that's called IVF. So really at this point, that's the way that you'd get pregnant would be in vitro fertilization or IVF.
But I don't have,
In the laboratory, then we get the sperm, we get fertilization typically by injecting the sperm and grow embryos, and then we can freeze the embryos. Then we, of course, ahead of time would have someone set up to carry the pregnancy, a gestational carrier. And then those embryos can be thawed when the timing's right, like when that carrier is available, when we're definitely going to use that person. There's a lot of details. That's all to be worked out later. So that's not something that we need right this minute. But then you can transfer one embryo back into this person who's going to carry it, the gestational carrier. Yeah. And then they deliver they gave me some of your records.
Okay, perfect.
Yep, that's what I thought. All right. Because... So there's one test that tells me, like, are you a good candidate? And the answer is yes. You got lots of things. That's what I needed to know. I just wanted to get that, to tell you the good news so you don't have to worry. Because I know on your mind you're thinking, what if it's not good, right?
Yeah, it's overwhelming.
according to this, it's your AMH, anti-Mullerian hormone. That value tells me how many eggs. So I always think of like a glass of water. How much water is in there? That's going to be the amount of eggs. Now, for women, you're only born with so much, and each month you just pour a little bit out, meaning that you ovulate and you release those. And it's not a big deal. Everyone does that over decades, right? So the quantity of the eggs slowly goes down. Not on a daily basis, but usually kind of like every couple, like 3 to 6 months, a little bit comes down. Your value is 7.9. And a normal value is 1 to 3. So you have more eggs than the average woman your age, which is a great place to be.
Wow.
Oh,
Yeah.
Okay, good.
Yeah. So we're in a good position.
Almost how full?
Yeah. No, you're still like brand new.
Yeah.
Yay!
You don't have that much mouse on
God,
you.
if I have my uterus, I'll be popping out these babies.
Oh, you would be. Yeah, back to back. Back to back.
Back to back. Oh, Lord.
Hey, but
Oh, my God.
So that's, I mean, we'll get back to the rest of this, but that's an important test. And of course, your age, which is still very young, 29, birthday, even when you turn 30, it's still going to be good.
Okay.
We got quantity, and good quality for your age. Now,
Do you see
what's
the
that?
quality also? Do they do a quality test?
No, there's not a great test for quality,
Okay.
but it's generally the age of the woman.
Oh, okay.
Under age 35 is the best. So, I mean, 29 is fine. Yep.
30.
30, okay. Yeah, we had him listed on here as being 7 years old. I figured that was a mistake.
Did I put something on it? I'm sorry.
oh my goodness, really?
No, when it's just an error in the system. When they make the new patient appointment, they had your information, but he wasn't attached to the chart yet.
Oh, okay.
So I had the paper. I knew he was there. They just didn't enter his data in.
Who's this?
And so
I'm
by
a
default,
cougar.
yeah, right. So by default, it says like 7 years old, and it's just it's.
I can birth you.
Yeah.
So,
Funny.
Oh Lord.
so this is good news. Yeah, and I'll come back to the rest of that testing, but I just wanted to mention that to you. Now, Pap smears look good back in 2019. They're normal.
Right.
No history of any pelvic infections, gonorrhea, chlamydia.
No.
Now, I know it says you've been trying for 2 years, but not, I mean, technically that's just or unprotected intercourse.
That was before. I think that was before our last pregnancy. Yeah, we had.
Now, are you currently breastfeeding?
No.
Okay. Because you can't breastfeed if you're trying to get pregnant with the next pregnancy. Yeah.
No, we're done. He stopped breastfeeding 2 months almost. 2 months almost.
Yeah.
About
Now,
a
what
month
did your
and a few weeks.
OB say? Because typically they try to say about 8 months to a year or longer in between pregnancies just for your body. So if you had a baby back in September, that's what,
8 months.
About 8 months. Okay.
So we talked to Dr. Kita. We actually had like a lengthy conversation with her, and she gave us a referral. She said that it's actually okay to start. So we're not looking to have the baby now, but we just want to, save the embryos and freeze them for like a couple years.
Maybe
Okay.
next year or something.
Next year? No,
Yeah.
I'm not ready. Maybe in 2 years.
Okay. Now, the first pregnancy, was it a C-section or normal delivery?
I had two. So the first one was a C-section. This was a normal delivery. But I ended up having the cats because they had to do the hysterectomy and stuff.
Gotcha. All right. No allergies to medications. It does say that you have anemia. Do you take medication?
I used to take iron supplements, but not anymore.
Because I would
think
think
the
without a
last one-
uterus, no bleeding, you should be okay.
Yeah, the last test I did was fine.
Oh, okay, great.
Yeah.
Yeah, let me take a look. It's right there. Mm-hmm. Oh, yeah, that looks really
Yeah.
good. Amazing.
So
Yeah,
it's
I
not
think you
all
figured out how
that
to fix it.
Yeah, and I used to have really heavy bleedings before, so I think that was why I was anemic. But since the anemia has resolved.
So, okay, then that looks good. Let's see. No other surgeries, correct?
No,
C-section,
C-section and the
hysterectomy.
hysterectomy. That's it.
no alcohol, pretty healthy person overall. Family history, mom, dad, brother, sister, all healthy?
No, no other medical things that I know of.
No medical issues, great.
No.
And this very last thing is family history, all these medical disorders, congenital problems, people born with issues. Nope, no genetics. Okay, great. And then a few things to go through.
Yeah, it's not.
You're a young, healthy guy. I mean,
I go to the gym a lot.
Does he need to do some injections or
it's like boxing over there.
medications?
I'm sorry. Go ahead.
Does he need to have any injections or medications too?
No, I'm good. I mean,
only if you want him to.
Please.
No, typically, generally speaking, the guys have it pretty easy.
very easy. Yeah. It's just smooth.
He has to just do a sperm collection when you need him, and that's about it.
That's it. You take the.
And how is that done? By himself or, through sexual intercourse? And, how does that happen?
No, it's a good question, but generally it's just by themselves, yeah. And
okay.
But I mean, I can get into details, but some guys will say, well, I just cannot do a collection without my wife, and then they have to wear a condom with no lubrication because that can kill sperm. They can do a collection into the condom, take that and put it into the collection cup. Yeah. But, there's a lot of error, like sometimes people forget or the condom breaks or they just put the whole condom in the collection cup and they can get abnormal sample results sometimes. It's better to just have the guy collect. And the way we're doing it now, and this may change because, vaccines have come out, but everybody used to be either at home or coming into the office. And then last year it turned into everyone just collecting at home just to prevent, exposure.
Right.
And that's kind of where we're at right now. Not a big deal, but he or you could come to the office here in Fair Oaks, get a collection kit. I know it's really nothing fancy. It's a brown paper bag with a little sterile cup in it. That's pretty much it.
Okay.
You do the collection at home, abstinence, no intercourse for 3 to 5 days. You'll have an appointment when to do collection, probably at home or on site, and then bring it in. And they have a pretty good urology lab where they look at the sperm test. And so when it comes back and it's good, then I pretty much trust that too. Then we'll get the results sent to us. What's that?
Hold on today.
The first round.
No, I think it's just one, right? Just one test for him?
Yeah, so generally it's going to be, that's the only clinical test that you have to do is do a sperm semen analysis. Okay. And the other thing would be a blood draw. And the blood draw looks for infectious disease testing. That goes for both. Now, your wife's already had it done, I believe. Infectious disease is required by the FDA, and that's what I'm looking for her. That's going to be gonorrhea, chlamydia, syphilis, HIV, hepatitis.
So what is the time frame because I did one when I was pregnant with my son.
Yeah, for us, it's every 6 months.
Every 6 months. So
then I probably would need another one. Yeah. I had it done 2020, early 2020.
It's been more than 6 months, so you have to get.
Yep. So you'll need that infectious disease testing as well. Now we can wait on some of that. Meaning we can sit down and say, hey, here's the plan. We can do IVF. You look like a good candidate when you're ready. Like, hey, we want to get this started in August, or maybe it's January of next year, or maybe it's as soon as possible. Then I would get that infectious disease testing done, because if it's more than 6 months, you got to get it done again. It's kind of wasting money to just keep doing it.
No, we want to do that as soon as possible. It's just the carriers what we're going to wait on a little bit, but we want to get the process
I got you. Yep. Okay. Possible. And then for that, what we need to do is to I have to put you in touch with our third-party team. Third-party team means donor egg or donor sperm, or which is not the case here, or gestational carrier. It's when you involve somebody else. Yeah. And that's fine. It's going to be a different set of nurses because they kind of specialize in different things. There's nurses that use, in this case, it'll probably be one of our nurses here, most likely at Fair Oaks, but then it'll be combined with nurses that help or assist with the gestational carrier. Now the question is where do you find one of these people? How do you work out the details? You need to get a law attorney. I know it seems crazy. Why? Well, it's pretty obvious. Think about it.
Yep.
Genetically, it's your baby. Someone else delivers it. In most states, whoever delivers the baby, it's theirs.
Yep.
So you want to make sure that when they deliver that you got a contract that says this person gives up the rights, it's yours. Yeah.
Right.
So yeah, I can just see that look on your face like there's no way someone's taking my baby. I know. So it won't happen because before all this gets started, you get a law attorney, and it's not really that difficult. I mean, for them, this is stuff that happens now more frequently than it used to. Maybe back in like 1970, nobody was doing this. So if you did it, you might have been one of the first cases. But now it's very well worked out, and they've got contracts, and people sign stuff, and And then how do you find somebody? This will be what to carry a pregnancy. This is what the gestational team can help you with.
Okay.
Because they have agencies where people want to do this to help someone out. Like, hey, well, I had a family member, not me, but like these people, they all have reasons for doing this. Helping other people is generally the big one. It could have been a family member who had the same thing that you did, wasn't able to carry a pregnancy. Now they want to help because they know what that's like. Most of these people are very well-intentioned, and it's good. They do make money, of course, but as you would know, going through 2 pregnancies,
there's no amount of money
it's
that's
really profitable. You make something, but you got to cover like their health expenses, the delivery. Let's say they get sick and they need to go to the doctor, that kind of stuff during a pregnancy. I mean, the same as it would be if it was you. Yeah.
Right.
So in that case, are they going to be on our insurance?
Sure, exactly. That was my next question.
Yeah, I don't know. That usually is worked out with the attorney.
Okay.
It may be one of those things where they just say, it's going to all go through that other person, and then when it's all done, they're going to add it up and say, this is how much it is, and that's what you owe.
Okay.
Right?
Okay.
That's generally, I think, what they do. Okay. Because otherwise it becomes very hard to every single time. It's like a kid asking you for lunch money. Mm-hmm. Hey, I need $5 today for lunch, and then tomorrow I need, and that gets old fast. It's just better to like keep a list, add it up, and then goes from there. Okay. So, Ben, just a few other things here. You look like a healthy guy, security engineer, no allergies, no medical problems, no smoking, no alcohol, no tobacco.
No.
Family history is pretty clean too, I take it, right?
Right.
Okay. The other things that we mentioned, just to get back into some of her tests, to look over this again. Your thyroid test looks good. This was all done just a couple weeks ago. Mm-hmm. Your prolactin was normal. The ultrasound. Let's see. When was this done?
I haven't had one done in so long.
Oh, okay. I was thrown off because the date says June 18th, 2021, and I'm having like a flashback going, wait a minute.
We're not even in June.
We're not even there yet, all right? But it says next appointment. Okay, that's physical therapy. All right. Portion of the cervix still seen. Yeah, so subtotal hysterectomy, the right ovary is not seen. Okay. Just going through this kind of page by page. I'm almost done.
It's okay. Take your time.
Supracervical hysterectomy. Good. Yeah, that's about as much as we got. There's additional testing that generally is done too when you guys are ready, which could be a few weeks, and that is, like I said, the infectious testing, a blood type. We look at a couple other little things like your immunity to varicella, rubella, making sure that when you get pregnant, well, actually, I guess that wouldn't matter for you, the varicella, rubella, because someone else is carrying the pregnancy. So that would be checked on somebody else.
We both have
but I can put you in touch with them.
Blood type.
Okay. Mm-hmm. So, and then that's about all we have. I mean, for what's been done right here. There's so many other tests. Interesting, like when there's no uterus, I have to like almost think, what don't I do, right? Because we normally would check the cavity, the tubes, and it's based on the menstrual cycle. It kind of makes it a little bit more simple when it's not there, but more difficult to carry a pregnancy, obviously. So not trying to make that sound like a small issue. We also need to get you to talk to one of our social workers as a couple. This is actually recommended/required by the American Society for Reproductive Medicine. Because as someone moves forward, the good news is you have experienced a pregnancy. But the next step is it okay that someone else carries this? I mean, they just talk to you about this kind of stuff. And I mean, I know you guys have talked about this and you want to do it. But it's just to make sure that, you know, your husband's not forcing you to do it, or you're forcing him to do it, or something like that. Most of the time, everybody with a social worker gets approved. I've never had someone not get approved. Okay. But it's just to make sure that you understand what you're getting into. That I mean, I think it's pretty obvious in a case like this, you know, because we're going to be using your eggs, your DNA, and so there's not too many surprises there. And it's for a medically induced procedure that we're doing this. So that's a social work consult. We talk about the legal attorney. You may be hearing from different nurses because there's the gestational care team and then there's the using your own eggs team. Now, and sometimes they actually combine them just to make it more simple. So I'm not sure what they're going to do until we talk to them. But I will be sending them a note in a few minutes when I'm done, about 10, 15 minutes after we're done talking, a note that sort of says what we're doing. And then they can reach out to you to kind of fill in the gaps in terms of getting all these things done. And then we can always follow up again. The good news is that we can probably get some of this at Kaiser to save you some money. But then when you actually want to get started, do you have insurance coverage? Some people with Kaiser do, most don't for IVF.
No, is there something like that?
Some people do. I don't know why. I really don't know. They have like a certain amount of money, like $8,000 or $10,000. Some people don't have anything. I think it's job dependent. Probably what was probably negotiated with an insurance company for that type of a job. Yeah. Oh. So now, mommy,
you're doing good.
All right. Are you working currently or not?
Yes, I work at Kaiser.
Oh, you do? What do you do at Kaiser?
I'm an RN.
Nice. What area do you work in?
Advice nurse.
Oh.
So I work from home.
Good. Like I said, Kaiser is good. If you do what they say, they cover you. They take care of you. That's the nice thing.
Yeah.
Yep. And I'm trying to think. That should be all that we need, so we can update a few things. Have all these different teams touch base with you. Social work consult. You got sort of an ultrasound done recently. It says they couldn't see one of your ovaries. I'm not sure why that is because it should be fairly easy to see.
That was a little. I think we had talked to Dr. Q-Tip about that. I was having some pains, and then they ordered the ultrasound to see what was going on, and I think the lady was finding it really hard to see it. And Q-Tip said sometimes, you know, the ovaries are pretty tiny, so they usually will not always get picked up on ultrasound, and they wanted to do I think MRI or something, but I didn't want to go through that. So
we generally get our own ultrasounds just to make sure that we can get to the ovaries. When someone's got a uterus, as you'd imagine, it kind of holds things in place. Right. But the ovary, we know if we see the uterus, the ovary's here and the ovary's there. Sometimes when the uterus isn't there, they're a little bit more floating around. Not that you're not going to see the right ovary on the left side. It's not going to be crossing like that. But it might be higher or lower instead of both at the same spot. So because in order to get these eggs, we have to give you injectable medications that you take pretty much every day for about 8 to 12 or 13 days. Okay. They're usually from like a...
Once daily?
Once daily, yeah.
At least it's not like 5 weeks or 6 weeks. Just 13 days, you know.
About 10 days, yeah. 10 days. And it's like the diabetic needles, right? The really small sub-Q ones. That's all.
I'll give you the shots.
Does it always have to be like the abdomen area, or can I inject it like?
Generally we recommend just to the left or right of the center, right of your belly button. You can do it in the leg or the arm. It's a little bit harder though. I mean, for you to do it yourself, it's kind of hard to reach your arm. Your leg, you can do it, but the leg tends to be
more
more muscle and more tender. Yeah. Usually the easiest place to see with less sensation is just to the left or right of the belly button.
Yeah, I just
Yep, harder to mess that one up because the medicines are expensive, and you know when you don't put it in the right spot, then you kind of wonder if you actually got the medicine.
Yeah.
So.
Right.
Yep. That's okay.
Let's see. I think that covers everything that I wanted to do now. We'll just kind of round off some of those tests, have these teams reach out to you. and then we can get it ready, get things moving, get some embryos. The embryos, the way we get those after stimulating your ovaries for about, I said 8 to, let's say 12 days. Let's say you come in today. Each time you come in, we get an ultrasound and blood work. Ultrasound looks at the ovaries, see how they're growing, how big, which ovary has which ones, how many. The blood work tells me the levels of estrogen. So estrogen levels, so as the follicles grow, the estrogen goes up. So you should be seeing this trend. Let's say you're here today, you're day 12, these follicles are ready. We give you what's called a trigger shot. That shot will help to kind of mature and release those eggs. But you don't ovulate them quite yet. Now, 36 hours later, under anesthesia, ultrasound probe goes in. So like the transvaginal probe goes in. We got a needle through that probe, through like a secure sleeve. Ooh. And that's the needle that we use to aspirate the fluid from the ovary.
Wow. It goes through the vagina?
Yeah.
And I'll be under like anesthesia complete?
Under anesthesia. You wake up, we're all done. And sometimes people are like, you already did the procedure? Like it's that fast. Yeah.
Wow. How long
does it take?
Probably 10 to 15 minutes.
Wow.
Yep.
You guys are quick.
But, to you, it'll be like 30 seconds. Like, what? Like, what? I'm done? Right? So it's just because of the amnesia part. You go, whoa, that was fast. Yeah. It's kind of neat. I mean, I think so.
You just close your eyes once and you open your eyes.
It's an important thing. Yeah. But we have to make sure that we can get to your ovaries. That's that's my point. Because every now and then, not too often, that someone's ovary is kind of far away now because we don't have that uterus holding it in that place that it should be.
Okay.
If that was the case, we may have to try something different to get to the ovary, but let's just first see. Should be fairly easy. That case here, they said they couldn't see that one, but again, when the uterus is there, it holds it in place. When it's not, sometimes the intestines or the colon can move up and it can block it a little bit. But I'm pretty sure we'll be able to get to them. Most of the time we are.
I know you guys will.
Yeah, it's really generally not an issue. Yeah. So we'll get testing finished for your husband as well, because we got to make sure there's sperm there. I'm sure there's sperm. You've been pregnant recently, but these are all things that you don't want to make assumptions, and then you get in there and spend all this money, and then you realize it's not working out.
Mm-hmm. Okay.
We want to get eggs and freeze them and not have some sperm. We've got to make sure that we got all the right ingredients before we get started. So we'll finish these things. We can follow up. And then it's always helpful to look at gestational carriers, like where do you get them from, agencies. I mean, you can use a known carrier. That's not a real common option because, you ask somebody and it's like, wow, it's a big responsibility. Yeah.
You don't want to put that responsibility on family. Can you carry my baby?
Yeah.
Right. Yep. So that's about all I got today. Let's see. I'll get my note done shortly. I'll send it out to both these teams. The nurses tend to respond pretty quick. The donor team maybe within 24 hours or 2 days at latest.
Yeah. Okay. Thank you so much.
Hey, you're welcome. Any other questions for me?
Yeah. Do we determine how many eggs are retrieved or how many embryos are made, or does that?
I would estimate, we can do a follow-up and get into some more details. I would estimate, based on your AMH, that you might make 15 to 20 or 25 eggs. That's a lot. If you think about it, you make 1 egg a month, 12 times a year, typically. That we could do about 1.5 to 2 years worth of work in about 12 days.
Wow.
We're going to fast forward this. Yeah. Now, I'm not trying to get all the eggs that I can. Like we don't need 40 or 50 or 60 eggs and freeze 20 embryos. I mean, now you got a problem. What are you going to do with all this?
I know.
So really, the goal is about 12 to 15.
Okay.
Because let's say you start with 15 eggs, let's say 13 are mature. Of those 13, 80% fertilization. Now you're down to 10, and of those 10, when they grow them out day 5 or 6, 30 to 50% will make it. So now maybe we're down to 4 or 5 embryos.
Oh.
So you don't always start with as many as sometimes people do get a lot more, but so you hopefully end up with a reasonable number. I don't want to get 30, 40 eggs and end up with 15 embryos. What are you going to do with all those? I mean, that's just a problem in itself.
I know. And you feel bad, like
you feel bad.
Some and just let go, just throw some away. It's like,
No, we just grab all of them.
What?
Yeah.
Why are you going to keep them?
We have a football team.
He's one positive guy. But just so you know, if you were to get to some issue like that, not too common, you can always donate them back to us. I know it seems like a strange concept. That way you don't feel like you're destroying them. And then other couples will use them. It's not a moneymaker for us. I mean, we sell it for kind of the face value. We're not selling it for extra to make money. It's to help other people. Like there's people out there who are trying and trying. You know, maybe that woman's getting older. The guy has like no sperm. They look at the options and they go, "This is not going to work. We can always try real adoption of a baby."
So then our biological kids will be born somewhere.
Could be raised by somebody else.
And what if they get old and get married?
What do you mean they get old and get married?
Like they meet each other. Oh Lord, that's
the probability of that. I know it's always possible.
That's like 1 in a million years.
Honey, okay. But it could say like they get picked around here in the DMV area. You never know where you meet someone.
Yep. It's always possible. There have been people that have looked at some of the probabilities of that, and it's so small. I mean, but you're right. I know. What are the odds, right?
Yeah.
Yeah.
Okay, well, we'll think about that. Thank you for that information.
Oh, yeah. But again, that's so far down the road. I mean, if you only have 3 or 4 good embryos, not going to be a problem. Not going to be a problem. The last thing to think about is we do offer a test called SEMA4. It's a genetic test that I do recommend, but it's not required. That looks to see if you have autosomal recessive traits, meaning are you carrying sickle cell? Are you carrying alpha thalassemia, cystic fibrosis, spinal muscular atrophy, Tay-Sachs disease? I
could be a carrier of thalassemia because the doctor mentioned that to me, but I don't know which one.
Yeah, as I say, because your mean corpuscular volume on the CBC is 77, and we're looking for about 80. So usually that means that the person could be a carrier. Yeah.
Right, but I don't know if it's alpha or beta, so I don't know.
So that's right. It's Kaiser. So Kaiser has their own test. Did they do that hemoglobinopathy panel? Okay, I'll make a note.
Okay, and then
I'll put hemoglobinopathy panel ? Because they usually do that one, and then when they do that, it'll break it down and say most likely it's alpha or beta. That's usually what they do.
Okay. And then you have to go through my OBGYN to request those labs, so you can just put them in and we can just go get it done.
So what we generally do is my nurse will help me start doing some of this. I'll make a plan. She'll help to contact Kaiser, kind of to update you. Contact Kaiser and say, hey, these are the things that we're kind of missing or we need to do. And then a lot of times they will do those things.
Okay. So they'll contact my husband when he's ready, to go do his...
I don't know if they actually call him because, we'll say he should call them and say, I need to make this appointment. And they'll go, oh, yeah, the order's there from your Kaiser doctor. But the Kaiser doctor put the order in because we told him that's what we wanted behind the scenes.
Gotcha.
Okay. So his doctor will let him, maybe when he's ready to go get it done?
Okay. Yep.
All right.
So my nurse will be in touch with you to kind of explain how we're going to